Okay, so we're going to start with the teaching of the cardiovascular system. It's competency number 5. And for this competency, you'll need to have on a sports bra, guys, with your shirts off so we can see your landmarks. So come prepared, dressed appropriately for that one. There's actually, I believe, 2 of them. That one and abdomen. You'll need to wear sports bra or t-shirt off because I need to see your landmarks on those on this second half. So just heads up. I think, yeah, those 2. Okay. So as always, you always start, and everybody did really good. So I'm glad we everybody said, oh, God, we all did so good with that part. We start with our introducing self. Hi, I'm Austin. I'm going to be your nurse. What brings you in? I do my hand hygiene. I provide my privacy. Right? We always start there with every assessment. That there's 3 points or 2.5 points right out of the top. And then for cardiovascular, somewhat, I always say somewhat similar to respiratory, but it's different indicators. When we're looking at our inspection, because remember, we do inspection first, we palpate last, right? And y'all did great on that. I'm like, don't be laying no hands on nobody. Like, don't be laying no hands on nobody. Tell me what you see first. Tell me what you see. Y'all did great with that. I was really impressed with your all. So it's always, we start with inspection. Tell me what you see, right? So color, as it relates this time to person indicative of someone having cardiovascular issues. Issues with perfusion is what we're thinking, right, Nate, right? So when we're looking at color, cleanliness, moisture, temp, texture, color, and vascularity, we're thinking about those things in terms of how it might be impacted by someone having a lack of perfusion. So at its worst, lack of perfusion, what might you see for color? Cyanosis, white, pallor, right? What are you hoping to see at its best for cardiovascular good perfusion? Pink, right? We want to see that nice, healthy, vibrant color on someone, right? The skin, should there be moisture? No, we don't want to tap them and they're all like moist and diaphoretic. That'd be a problem, right? We want that skin to be dry. We want it to be nice and warm. We want the texture, ideally, it would be somewhat soft. It's moisturized, it's not dry, it's not scaly, right? We're looking for vascularity issues as it may relate to, again, poor perfusion. So any areas that may not look like they may not be having perfusion well, or any kind of lesions that may not be healing well, those could be indicative of perhaps not getting the full thrust of the benefit of a good cardiovascular system, right? And then chest wall configuration, again, symmetry, it says bony deformities. Okay. And heaves. Heaves are lifts or rises, which you'll see on the chest wall. When you're looking at the chest wall, and this is again why you can't see them through clothes. You need to be able to see someone's chest. That's why I said I need sports bra or t-shirt off, because I need to be able to see your chest to see if there's any heaves, which will be areas where you see it lifting up a bit. And this could be a sign of heart enlargement. We don't want to see that. We don't want to see any lifts or heaves on the chest wall when you're looking at the chest wall. A little rise. You see, it's almost like it's trying to come out. It's a lift. It's literally a lift, or it's the whole chest, or just over the heart area you're looking for. This is this is a cardiovascular thing. So you're looking over the chest wall area, right? You're looking for that area in this region. What side of the body the chest is the heart on? Okay, so I go back to basic anatomy, right? So we're looking more so like it sits on this side, right, of your chest. So when we get to heart sounds, that becomes important to understand why we're on this side, and why I don't want you on the breastbone. Ding, 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 that'll get you dung, because I'm like, why are you on the sternum? And why you're not on the right side, right? You need to be be mindful on this one that the heart is sitting here on the left. And it's about probably the size of the fist, a good size heart. So we expect to see it if it's having issues. I'd be looking particularly over that chest wall, left chest wall area, mid left of the clavicle. I'm sorry, left of the sternum. Right, that makes sense. And then again, nail beds, which you should know. Now you all know nail beds. All 4 extremities. Make sure to take shoes off. Remember, for reals, I told you I wouldn't put my feet up on camera. That would not be a sight to see. But I think in my video, you should see me doing it on my student. I think I'd show you his feet. He has nice feet. Mine are not so beautiful on camera. I won't torture you with that. But you do want to hit all 4 extremities, particularly when we're doing these for real, right? Where it says bilateral upper, bilateral lower. Be mindful of what you're checking for. Capillary nail beds. Very impressed today as well that you were not giving me your less than 3-second business, because I don't like that, right? That's not a good assessment. A good assessment is, what is it? Is it 1 second? That's very different than a 2-second or 3-second or 5-second, right? Refill for cardiovascular, particularly for any time you're checking out that capillary refills. The information, we know normal is less than 3. We know that, right? But what is it for this patient? That's what I want to know. So when you guys were doing those, you notice I would step in closer to you. You notice I start hovering over you because I'm starting to look to see what the heck y'all were doing, because I was counting it too. And I'm like waiting for y'all to give me some, what I was going to call false information, which y'all did really good today. I say I was very impressed today because you were calling it as you saw it. Like, tell me what you see. The accuracy of the baccalaureate prepared nurse giving an assessment. That's what we're raising you to, right? So right, you got general stuff in your ABM, but let's hone and fine tune that language. And great language today, by the way, as well. So, okay. So then we done our inspection. Next one, it's asking us to do auscultation, and then we'll leave palpation last. Oh, this is not comfortable. Now, for this one, I'm going to give you an acronym to remember. I hope it shows on the video. It may be backwards. We'll see. Ape to man. You need to know that. Ape to man. It's showing correctly. Let me get my head out of the way. Ape to man. And this will save you on this section if you get cardiovascular. So what is that? Let me do that one first. I'll do them a little out of order. Well, I'll do them in the right order. Carotid arteries for bruit. You do one, you never do 2 carotid arteries at a time with your stethoscope. It says hold breath, use bell and diaphragm. Checking for bruit, a swishing sound. Hold the stethoscope, have them turn, Question? Hold the breath. You listen, hold the breath. Other side, hold the breath. Don't occlude both arteries at the same time. Listen, bell, hold breath, listen, hold breath, listen. You should not hear a bruit. You don't want to hear anything. Bruit is usually indicative, usually I say of a heart problem. An abnormality is swishing. I usually think things like hypertension. I don't want to hear a bruit. And then on page 400 to 406, I'm sorry, 400 or 406, depending on your old book or new book. 400 or 406, depending on which book. Ape to man for cardiac points will come in handy. Rate, rhythm, murmurs, bell, and diaphragm again. Ape to man, aortic, pulmonic, points, right? Ape. T, tricuspid, to man, mitral. Ape to man. Apical, pulmonic, point, tricuspid, mitral. That help you? Ape to man. So what the heck is that? These are the best places to hear for murmurs, or if there's problems in that area. Normal, we hear, you should know, We see it on our little cardiac monitor. Blip, 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 blip. Sounds like lip doop, lip doop, doop doop, doop doop, lip doop, lip doop, lip doop, right? That's your cardiac sound. So when you put your stethoscope to these landmarks, that's what you're listening for in these different landmarks. Is it regular? Are you hearing that lub dub the way you should? So where are these landmarks? Aortic, here they are. Let me do it. I'm on video, so that's weird. I'm backwards. Let me not watch that. So aortic is on the right side. You're starting on the right side. Here's the sequence, kind of like we did with our lymph nodes and all this stuff. We're going to do the same thing with peripheral pulses. There's some other series. This is your money maker. This has two money makers. This one and the pulses below. Aortic is on the right, second intercostal space on the right sternal border. So feel your intercostal spaces. We all did clavicle because we did that one for our public. So feel one, and then feel down. Come 1, 2 on the right side. Find over to your sternal border. I got a big sternum today. What, my sternum today over there? God, I can't get in there. Okay, it should come. Oh, there it is. Okay, in through there. There I go. Okay, I got sternum right there. I'm like, I have a big old sternum. I guess today. It was small. It was small yesterday. It was a little sternum yesterday. Okay, get it? Right, second intercostal space on your sternal border, not on the sternum. Feel your sternum, your landmark, your middle. Don't want that. It's right there on that right edge. That's aortic. Pulmonic is on the left, second intercostal space, right opposite that. So you just flip that thing over to the left side. Second intercostal space. Erb's point on the left, go down 1 notch to my third sternal place, and I hit Erb's point. And I just did 8. Tricuspid, 4th, 1 more down. And then mitral hits 5th, but you got to go over to the midline, mid to the breast line. So nipple line right over through there. So you may have to move breast out of the way, go over, under, work around. Mid is 5th intercostal space at the midline on the left. So what does that series look like? Again, I'm not taking my chest off. I'm an old guy. That wouldn't be pretty, but you can see my beautiful student online. Start on the right, second intercostal space, right sternal border, right? So A, right over to P, down 1 to Erbs, down 1 more to tricuspid, and then over at nipple line, that should put you about nipple line 4th, 5th to mitral down here, right? There's a series to it, right? Do. What do you hear in these different areas? There, I don't know if she put videos for there or not, but if not, you got my playback. She did, I saw something on here for a resource for you for cardiovascular. It was heart murmurs, heart sounds made easy, I see here. I thought I saw something else cardiovascular, but it's in your book. It's in your book. The book has great pictures. That's why I gave you those page numbers. I gave you your page numbers for that, right? Okay, wait, hold on. Let me pause. Let me pause. All right, so then we move down to our palpation for cardiac. And of course, we start with our palpate anterior chest for tenderness or thrill, right? It says. So again, Palpation is always this part of the hand. This is what I should be seeing. Much like for your palpation of your stuff, it was these fingers that are picking up the information and sending information to your brain. They're very sensitive. Palpation is going to be this part of your hand here, not your whole hand. I'll need your whole hand in there. This is what will register to your brain, what you're feeling. So know that, because you're going to need that tool for your abdomen assessment. So it's the same thing when I'm feeling for any kind of thrill. And what would a thrill feel like? It feels like, as I'm feeling, a cat purr. Anybody have cats? Know that little thing when they purr? That little thing? That's what you're feeling for. And you don't want that. And of course, as you're palpating across the chest, we want to palpate anterior chest to see if there's any kind of tenderness that anybody would be having here. Hopefully not, as you're doing a light palpation of the chest wall area. So palpate the entire chest wall area.
I have a question. When people complain of like tenderness or pain like in this area, in this region, is that cardiac or could it be like more muscle?
It could be cardiac, it could be muscle, it could be bone, right? So it could be ribs. You could be pushing on something. So therefore becomes a thing to rule out, right? So obviously they'd rule out probably an EKG. They'll probably want to do a chest x-ray, right? Then probably look at some enzymes, see if it's cardiac. Could it be, or is it some kind of underlying issue with the chest, or is it just the muscle, right? And then I obviously want to see the skin. Is there any bruising in that area, right? Somebody hit them, blunt trauma, somebody got beat, what's the name? IPV, intimate partner violence, right? Those kinds of things that are out there, and particularly those who are ER. Anybody work ER? That's where you see that kind of stuff at. ER, and my other one, who's women's health? Women's health is the other area I always like to raise flags around. Because we have
domestic violence. Domestic violence there.
Domestic violence, and also we have a thing with sex trafficking. We have huge issues with that go missed by nurses. So I'm a public health nurse. I'm gonna put my other hat on real quickly, just to take it off. I'm teaching health assessment right now, but I guess it ties into both. I guess a split hat, because I'm talking about health assessment, that as nurses, we oftentimes miss those things in those key areas of intake. So if you see bruising or discoloration, right? Does your head go to, wow, somebody that looks like blunt trauma? Did someone hit you? It's the same thing in maternal health, women's health. If I see these kinds of things on a woman's body, does my head go to, oh, I wonder if she's being beat or sex trafficked? Or am I just going to, oh, whatever story she tells me, oh, I bumped into something, or my kid did that to me. And we just write it and keep moving along in our assessment because we're trying to get done in a hurry, right? But these things are out there and they're happening and by volume, and they're going undetected. So it's always my public health plug. So if you're seeing someone with any kind of problem or pain or discomfort, or maybe I think about somebody who may have a rib crack or busted, I don't want any tenderness here. When you palpate your own chest wall, you should not be feeling any areas of tenderness. That's a problem. They got hit in the rib or got busted. That's not good. Whatever the issue is, that's not good. Those are all positive findings that require some additional follow-up. Right. Palpate and identify apical pulse. Yes, it says. I call it PMI, point of maximum intensity. It's on page 426. And this basically is the, where am I at on camera, looking camera? Left nipple area. It's right here. It's right where your nipple is. It's the midline and the nipple area. Those are your landmarks. Mid-clavicular. So we know the clavicle. Some of y'all, I was playing with the clavicle to run. Like I had a long clavicle. My clavicle runs from here. Let me just not look at it. Let me look through my landmarks. And if I palpate my clavicle, I can feel my clavicle way up to here is where it ends and goes into, right? That's a long clavicle. So page 426 I have here. 426? You old book or new book? Looks like the books are off by, what did I say before? About 6 pages. So go, maybe it's on it's either 420 or 432. You can let me know if I need to update my notes. It was 426. Apical pulse, see it? I can't see that far, but what does it say? Does it say apical something?
What do you mean, 3?
Okay, so point of maximum impulse is on page 400, just a correction. And then for palpate the major arteries, and this should be a series. Before we do the series, what are some of the, let's do our words for pulses. This is where we do our pulses. What are some of the words for pulses? So we all know regular and weak, thready, bounding.
It's like thumping.
I haven't heard of thumping. What's that? Bounding, thready, pounding, weak, faint. Okay, good. So everyone run this series with me. On yourself. It's temporal, carotid, brachial, radial, posterior tibialis, and dorsal tibialis is what you're going for. Temporal pulses, you should feel up. Let me take my glasses off. Temporal pulses, these 2 fingers. Feel, if you can feel your temporal pulse. Oh, there it is. There it is. Mine's here. Dun, 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 dun. Can you get the rhythm? Is it regular? Is it the same left and right? Okay, carotid, slide down 1 at a time. We don't occlude 2 carotid at the same time. I'm gonna give our brain some blood. Don't pass it out on you. 1. Two. Brachial is in the arm. There's places you get them. Sometimes you get them here, or you can get them up in through here, or you can get them in through here in the inner arm. These people will feel their brachial. Brachial is hard to find sometimes. Oh, there it is. Oh, I got it today. I went right on it today. It's right here. Because you know where it's coming through. It's coming through right here at your point here. So just follow upstream a little bit and maybe bury them under your muscle. Okay, and again, comparing left to right, always compare left to right. Oh, that was easy to find. That was much easier to find on my right side. And then radio, we all know radio pulses. We do these all the time in a hospital and put it on camera. We know radio pulses, right? Comparing left to right. God, I'm tacky. Must be that darn coffee. I'm tacky today. Oh, I'm tacky. Okay, and then we go posterior tibialis, which is inside on the great toe side. You put your foot up. It's on the great toe side, posterior tibialis, on the ankle. I'll put my shoe sock on. Posterior tibialis. I'm not as young as I used to be. Inside on the great toe side. Do you feel it? And then your dorsal, oh God. Things I'm doing for you on video. Dorsalis tibialis, usually on the top of the foot. Again, it's usually a ridge here, you'll feel it. Yeah. As young as I used to be. It's not going to be my finest video. I did it for you all. Remember, that's bonus points for me on my evaluation. He's 60 and went out of his way to put that foot and leg up there for his kids. His students get the best. This is Cal State Fullerton students, you don't mess around. Okay. And again, of course, we know how to do our edema checks, all four extremities. And beautiful, you guys, that we don't do, and this is kind of out of order, I'd be pet peevy on this. I probably would do edema earlier. I wouldn't go from feet up to face or feet up to anywhere without retouching my sanitizer, right? Just FYI, I don't go from my feet, my own feet. I don't want to smell them. Now I'm gonna check your sinuses. No, don't put my feet in my nose, right? So let's be mindful once we go to someone's feet that we don't go back up to their whatever without re-sanitizing ourselves. So edema checks for our hands and our feet. So you got to work that into your routine. And that would complete that assessment on cardiovascular. So my other note here says that the diaphragm is best for S1, S2, and the bell side is best for S3 and S4. I can do it again. Diaphragm is best for hearing S1, S2, and bell is best for hearing S3, S4. You'll get your theory too. You can read your book in theory to get all that. But you know I gave you the basics so you understand it. But just so you know why you're using both. Okay? All right, so that's that section, and we're going to pause and practice.